refresher and video, and I'm going to go through a neuro check. So we're going to pretend that this patient is awake and can follow commands. If you want to know how to assess a patient who is unconscious and unresponsive, that is a very different set of assessments that we have to do, and I'll have links in the description of this video for tips on how you can walk through an unconscious assessment, but that's a different video. Okay, neuro checks. The first thing that you want to check on your patient as you walk into the room is just observe how the patient is acting. Are they eating their food? Are they watching TV? Are they on their smartphone or laptop or talking to someone? And just observe if they're able to move their extremities appropriately, if they're like eating their food. How's that going? Does that look normal? Just really observe how they're doing, because even in that, before you step into an interaction with them, you can gather a lot of information. If they're, purposefully moving both sides, if they're able to carry on a normal conversation with someone, that shows us their speech is doing great. And speech issues are very common in strokes and neurological injuries. So observe before you jump into the interaction. Next, when you chat with them, level of alertness is really important, level of consciousness. When neuro changes occur, they first occur in that level of consciousness, okay? It's very subtle and they happen over a longer period of time. It's not like vital sign changes that can flip on a dime. Now, while that can happen where you have an acute neuro change like that is certainly the exception and not the rule. Neuro changes are slow and subtle over a long period of time, which is why it is incredibly crucial that at the beginning of your shift, you get a very good assessment, okay? So I walk into the room, I'm noting, is this patient awake and alert? Are they lethargic? Are they obtunded? Are they stuporous? Or are they unresponsive? Now, if they're unresponsive or stuporous, I'm hoping they're not on your neuro floor. They should probably be in an ICU or a step-down environment, so keep that in mind. And if you want help on differentiating between those levels of consciousness, there is a different video that I have that I'll have linked in the description where you can check that out as well, because that needs a little more explanation than we're going to go through in this video. So I'm going to interact with the patient. Hey, how you doing? What's up, Mr. Smith? How's your day going? And I'm noting level of alertness. Then I go into my orientation questions. Hey, I'm going to ask you some questions that are probably going to be a little basic and straightforward, but I want to make sure I see how your orientation is. So you ask them, what their name is. Even if you already said, hey, Mr. Smith, have the patient verbally say their name if possible. If they can't, we're having speech difficulties and speech issues, you can always turn it into a yes, no. Okay, I'm going to ask you some questions. Is your name John? Yes or no? Is your name Michael? Yes or no? And then have them, be able to figure out if they can remember their own name. Very important to do. So the name, where are you right now? Are you at home? No. Are you in the hospital? Yes. Are you at the grocery store? Are you at the school, or whatever it might be? Do you remember why you came into the hospital? And see if they can understand the situation. And even, I'm happy if they even just say, I had a stroke. That's helpful to know that they're oriented to the event that just happened in their life. Even if they can be a little bit more confused, they at least know that they had a stroke or whatever their injury is. And then you also want to make sure you assess time. And when I assess time, I usually ask them, do you know what year it is? Do you know what month it is? What holiday did we just have? Because I have found that if you ask day of the week, a lot of people actually don't know the day of the week. Especially if you're working night shifts, you probably don't know what day of the week it is. And then I also used to ask who the president is, but that has become a very volatile question, so I avoid that one. So, month, year, recent holiday, that kind of thing. So that would take care of your level of consciousness and orientation, and you do that very, very quickly. Let's talk pupils. So you are going to have a pen light, and I actually have one that I really like that I could not find, but it's one that I'll put a link to it in the description. It has a keychain on it, and you can put it with your badge. I love that. It's always with me. I don't have to worry about having an extra thing in my pocket. So you're going to have your pen light. You're going to check their pupils. Okay. So what I like to do is I like to tell the patient to look at my nose, and then I will take a pen light and I will turn it on right in front of their eye. don't make the mistake of sweeping it in front of their eye, because as you get closer to the front of their eye, the pupil is going to start to constrict, and it's harder to quantify the change if it's already getting smaller as you pull the light to their face. So you're going to have them look at your nose and then boop. And then what I'm watching for is multiple things at once. I'm taking note of the shape. Is it irregular? Is it oval? Is it circular? So I'm paying attention to that. I'm also paying attention to the size it was when it started and then what it shrunk down to. Were we at about 3 millimeters or 4 millimeters and we get down to 2? I'm also noticing how quick that the pupil responds. Is it brisk? Like, does it real good, smooth contraction and it stays there? Or does it not move? Is it non-reactive? Is it sluggish, meaning it does constrict but it's pretty slow? Or does it do something called hippus? Does it get smaller and bigger, smaller and bigger? Very important to know which one of those. So you're going to look at this eye first, and then with the second time that you shine your light, you're going to look at the other eye to make sure that it is also constricting appropriately. Important thing to know is when you're going into your neuro patient's room is just pay attention to see if they've had cataract surgery or some other eye surgery that might change how their pupils look. After I check their pupils, we're going to now do their extraocular movements. So I want to make sure that their eye can move in all of the directions. So this is very simple. All I do is say, hey, look at my finger with both eyes. Can you see my finger? Yes. So then you can do, have them go all the way up, follow my finger all the way down, and do a cross. Another one too is you can just draw a big circle with your finger and just make sure that they can move their eyes all the way around. That one is checking cranial nerves, I think 3, 4, and 6. The next thing is visual field. Okay, visual field is where we're going to close one eye with our hand, or you could tell them to close their eye, but it's kind of hard to hold it closed. So I usually go like this, and I ask the patient to look at my nose. Then I say, okay, tell me when you can see fingers wiggling. And then as I get here, they should be able to see, while looking at my nose, my fingers coming in their peripheral vision. And I imagine a big at cross here, and I try to do all 4 fields of vision so that I can see, tell me when they start wiggling, tell me when you start to see wiggling, like this. And then, or you can also do numbers. So how many fingers do you see here? How many here, how many here, how many here? And you do that for both eyes, okay? So that's assessing cranial nerve 2. So you say, no cheating and whatnot, and do that for both eyes, and you're checking to make sure that all 4 quadrants on each side the patient can see. Okay, so the next one is facial symmetry. Facial symmetry is cranial nerves 5 and 7. So throughout this entire interaction, I'm watching their entire face. Does this side move easier or more? Or, is one side completely paralyzed? And so what I'll do is have them raise their eyebrows, close their eyes really tight, smile, stick out their tongue, and see if their tongue deviates to one side, and that's me checking their facial symmetry. So that gets us down here, okay? That's most of our cranial nerves. Now we're going to do a motor assessment, and my patient does not have arms or legs, so we're going to ignore him for a minute. Okay, for your motor assessment, the next thing I do is I ask them to grip my fingers, and I have them put their, grab my 2 fingers, and a little neuro nurse tip here. Don't give them your whole hand, because if you have a patient who's can't follow commands or is, aggressive or whatever, I've had times where I put my hand in and they hurt my knuckle pretty bad. So just give them 2 fingers, because you can always pull those out if they can't ungrip their hand. So you give them 2 fingers, you have them squeeze, and you're noting if they have equal strength and if they can follow that command equal strength. And I ask them, okay, push me away from you and pull me so that I can feel the strength in their arms as well. And then I do a drift check. So a drift check is I ask the patient, can you close your eyes and hold your arms up like you're holding up a pizza box, like this. And what I'm doing, and I will count to 10 out loud and say, okay, I'm going to count to 10, and then I'm watching their arms. Okay, what I want is their arms to stay up like this. But if they have a drift, that means that one or both arms over 10 seconds comes down. You may have it where you hold their arm up, and then as soon as you let go, falls to the bed. You may have one where you say, okay, hold it for 10 seconds, and they slowly lower it under some control. Instead of a fall to the bed, it is a lower to the bed. You may have some where they hold it up and they just a little bit over the 10 seconds, or you may have someone who pronates in and goes down. That would be a pronator drift. So what you want to do is notice, is there a drift at all? And not just yes or no, but quantifying how much of a drift. Did we go from here to here? Did we go 6 inches? Did we lower to the bed? Did we just have a little bit of a bob? Like bobbed the whole time? You know, whatever that might be. So quantifying that. Okay, so that's your drift check. So that gets me done with my arms for right now. And then finally we do legs. So you have them, I put my hands under their feet, say push down like you're pushing on the gas, noting equal strength. And then I do the same thing, except I put my hand on the top of the feet and I ask them to pull their nose up to their toes, you know, so I can feel, you know, the strength there. So that's dorsiplantar flexion. Then I do a drift check for their feet where I say, okay, lift your leg, keep your leg straight, lift it up off the bed. And usually, you know, I have it kind of that far off the bed and I count to 5 and I will show them me counting, and then I let them put their other leg down, you know, switch legs and make sure there's no drift. And that, again, you're noting the same thing. Did it lower all the way? Were they even able to hold their leg up? Did it just lower a little bit? What's the situation? So you do a drift check on arms and legs. And then you can do your plantar stroke where you take, you know, a pen or you know, make sure your finger is really stiff and you go up the side of their foot or up on the bottom of their foot, but up the side so you can see if their toes fan. That would be a plantar stroke. And then the last thing I do is a sensory check. So what I do is I ask the patient, you know, close your eyes and I want you to tell me if you can feel me touching you on the left side, on the right side, or both. And I will do face, arms, and legs. So I'll say, you know, right, left, or both. And then they'll tell me where I'm touching them, right, left, or both. And then I'll go down to the arms and do that, and then the legs. And that's my sensory check. And that's it. I'm done. Bada bing, bada boom, right? A quick note about sensory check. Some people and some charting says for you to distinguish dull and sharp. I have found through my charting, through my hospital policy and talking to neurosurgeons and neurologists that during my routine neuro check, getting out something to distinguish between sharp and dull was not really necessary. So I would find out at your hospital if you truly need to check that every 4 hours, or whatever their policy is. I found mine, they didn't feel that was necessary, and that was only, you know, if I was having an issue, would I investigate that further. So, you know, do whatever your hospital says you should do, but that encompasses what a normal neuro check would be. I would make sure that you're documenting it thoroughly, you know, make sure that first assessment is spot on, because you're going to refer to that throughout the day if you're not sure if a change is occurring, you have to think back, is this the same patient I assessed at the beginning of the shift? And document everything you saw. And that concludes my neuro check. We're going to do a real quick reminder. First, you're going to do level of consciousness, then orientation. Then we are going to do pupils. We're going to do extra EOMs, extraocular movements. Then we're going to do visual field. We're going to check our facial symmetry. Then we're going to go down to our motor assessment with a drift check with a grips and strength. Same thing down to the feet, drift check again, strengths, and then a sensory assessment and a plantar stroke. And that's your neuro check. Sounds like a lot, guys, but you are going to be able to get so quick with this. Don't be discouraged. It's kind of like learning how to shoot a layup or in basketball. If you've never been given a basketball and stood in front of a hoop before, trying to remember all the okay, my arm goes here, this goes here, and trying to put all those pieces together feels really clunky and mechanical at first. But once you get the reps in, the muscle memory in, and you get memorized, it's going to be very fluid, very natural, and you're going to be able to just fly through that assessment without even really like actively thinking so much about getting this. You're going to know it backwards and forwards, much like once you get used to shooting a basketball, you don't even think about it, you can just do it, right? So that is our neuro assessment. You're going to be an amazing neuro nurse with great neuro checks. If you need more neuro resources, which we all do, right? I've got plenty of them listed in the description of this video. In particular, my neuro nurse crash course called NeuroWise. It helps you walk through, assessments, disease processes, and so much more to be a successful and prepared neuro nurse. Thanks, nurses. Stay fresh.